nothing to disclose. Let me introduce the topic. The hematopoietic, we are going to explain and talk about the hematopoietic stem cell transplant types, sources of stem cells, the sources considerations, stem cell collection and processing, and transplantation process. Of course, I'm going to consider post-transplant activities for our patients also. The stem cells are obtained from a prospective recipient related or unrelated donor, can be harvested from bone marrow, peripheral blood, or cord blood and placenta. High-dose chemotherapy with or without the radiation, with or without immunotherapy, prepares the bone marrow for the infusion stem cells. And healthy stem cells restore hematopoiesis and reestablish immune system function. The objectives are sources of stem cells and their characteristics, the commonly used terms and acronyms, most common sources of stem cells, process of obtaining or collecting stem cells processing, storage, and preparation, direct application of stem cells, the transplant process, acute and chronic graft versus host disease, and resources for donor search and stem cell acquisition for those patients who doesn't have a sibling donor. The stem cells that form blood and immune cells. The multipotential hematopoietic stem cell has a very important option in the hematopoietic stem cells collection because this very complex activity, the hematopoietic function, has many activities into the bone marrow. The stem cells have renewed itself, but during 7 days, they are differentiation, proliferation, up to get the thrombocytes, leukocytes, and red cells before going to the peripheral blood. This very interesting and complex activity into the bone marrow is under cytokines regulation. We have many diseases treated with hematopoietic stem cell transplants, a variety of non-neoplastic disease, immune disorders, and malignancies. And the different diseases who are going to option to transplant with stem cells are leukemias and lymphomas, bone marrow diseases, multiple myeloma, inherited immune system disorders, hemoglobinopathies, inherited metabolic disorders, and myelodysplastic syndromes. Here you can see some of the diseases who are going to stem cell transplantation, autologous or allogenic. Three types of hematopoietic stem cell transplant: autologous, from self to self; allogenic, from another, a sibling donor related or an unrelated donor; and the SYNGENEIC, from identical twin, also allogenic. How about autologous transplants? Autologous transplants are used to restore bone marrow function after chemotherapy with or without total body irradiation. And the three diseases who are going to autologous transplants are lymphomas, Hodgkin and non-Hodgkin, solid tumors like neuroblastoma or germinal tumors, and multiple myeloma. The autologous transplant process include collect from the patient's bone marrow or peripheral blood, processes in the lab to purify and concentrate the stem cells, cryopreservation to preserve. After that, the patient is conditioned to eliminate the disease in the case of potential minimal residual disease, and cells are infused into the patient, at the moment of the transplant. Autologous transplant has advantages and disadvantages. The advantages are perfectly matched donor because it's a self, no risk of graft versus host disease, rapid engraftment, low transplant-related mortality, and low risk of de novo infection transmission. The disadvantages are potential contamination with patient tumors, no graft versus tumor or graft versus leukemia effect. Prior therapy may limit amount of stem cell available, and prior therapy also may have damaged stem cells. How about allogenic transplant? Allogenic transplants are used to correct defective hematopoiesis, immunodeficiency, and exert HSCT graft versus tumor and GBL graft versus leukemia effects against malignancies. Once again, the process is similar, but the collection needs to make the collection from donors from bone marrow peripheral blood or cord blood. The process in the lab is to purify and concentrate cells, the stem cells identified by the CD34 by flow cytometry, cryopreservation to preserve sometimes, and the patient receives conditioning to eliminate the potential disease, and cells are infused into the patient. The advantages of allogenic transplants are free from disease, GBT or GBL effect may allow less intensive conditioning, and potential for minimized risk for tumor relapse. The disadvantages, availability of suitable HLA matched donors limited. You have to know that only 25 to 30% of patients have a sibling donor. Risk of graft versus host disease. The potential for graft rejection, immune recovery may be lower, and risk of blood-borne infections. The SYNGENEIC transplant is extremely rare allogenic transplant because require an identical twin donor. The advantages are not contaminated with patient tumor cells, no risk of GVHD due to identical HLA antigens, no need for anti-rejection therapy, and the disadvantages are no GBT or GBL effect, risk of relapse if disease is inherited genetic disorder, and risk of infectious disease transmission. Allogenic algorithm for hematopoietic stem cell selection. You know that only 25 to 30% patients have an identical sibling donor. At least 6 to 6 HLA, A, B, and DR are needed for the matched sibling donor. In the case you need an unrelated donor, you have to go to the HLA A, B, C, and DRB1. The best one is 8 to 8, but you have to admit 7 to 8 with HLA ABC and DRB1 in a mismatched unrelated donor. In the case of umbilical cord blood, you have at least 4 to 6 according to the lymphocyte naives into the cord blood and placenta. And you have also a third option, the haploidentical transplant, where you have a half HLA match. In this case, you need to know the HLA ABC class 1 plus the AR and DQ. According to the potential haplodonors, patients could have at least 19 to 95 options to have a donor half match. Of course, do you remember the HLA complex is into the short arm of the chromosome 6, and we need to know some preference at the moment to choose or admit an unrelated donor. These are younger donors, non-transfused male or nulliparous females, and C and B cytomegalovirus negative donor for cytomegalovirus negative recipient. Three main sources of hematopoietic stem cells. Bone marrow is collected under anesthesia in a surgical room using an invasive sterile procedure. Peripheral blood is collected using an apheresis machine after cells are mobilized from marrow into the blood, and cord blood is collected at the moment of delivery of placenta, and this collection could be intra or extrautero. Here you can see the process of transplant. On your left, the conditioning treatment could be chemotherapy with or without radiotherapy. On day 0 is the transplant, autologous or allogenic. And after that, begin the immunosuppression and the needings of prophylaxis and treatment of potential infections, potential appearance of graft-versus-host disease, only in allogenic transplants. And you have to know the transplant outcome according to the age and fitness of our patients, response of tumor to chemotherapy, radiotherapy, and GBL effect, only in allogenic transplants. On the right, you can see the immune system recovery, and you can see that the natural killer cells are the first one, and the last one to recover are the lymphocytes B. What about the history of hematopoietic stem cell transplant? The bone marrow, many years ago in 1939, attempted a transplant for aplastic anemia patients. During the 50s, 3 principles of hematopoietic stem cells appears: preparative anti-leukemia regimen needed, new immune system helped prevent leukemia relapse, and new immune system could attack host. But the histocompatibility antigens unknown. In 1960, Jean Dosset developed methods to identify leukocyte antigens. And 20 years later, in 1980, Jean Dosset received the Nobel Prize in Physiology and Medicine. During the 70s, pioneering clinical transplants began. Donald Thomas, who is one of the pioneers in stem cell transplantation at the Fred Hutchinson Center in the United States, has developed the first cure in acute leukemia myeloid anemia in the 70s, and he receives during the 1990 the Nobel Prize in accordance to their works. That I have to tell you that Donald Thomas at the beginning carried out the first transplants in the 50s in dogs using high dose radiation. And Donald Thomas and Dr. Joseph Edward Murray have received in 1990 the Nobel Prize also for their works or their research. The bone marrow collection, they harvested under anesthesia under sterile conditions. Prior donation of autologous red blood cells common to offset red blood cell loss during the harvest, because the donation goal is going to 10 to 20 milliliters kilogram of recipient weight, and 11 to 14 gauge needle attached to syringes used for aspiration. In general, 2 medical doctors, and the aspirations are to the posterior crest, iliac crest. Marrow added to the collection bag containing anticoagulant and requires 2.3 per 10 to 11 to per 10 to 8 nephlet cells per kilogram recipient weight. You may be done during the harvest CD34 positive cells counts, and the collection is taken to laboratory for processing and may be refrigerated for 24 to 28 hours or frozen for later use. How about the history of peripheral blood? In the early 70s, successful collection of colony-forming cells. But the continuous flow of fluorescence technology developed before. During the 70s and 80s, peripheral blood for hematopoietic stem cell engraftment failed because of low concentration. In the mid-1980s, strategies appears they induce a rebound of peripheral blood hematopoietic stem cells after chemotherapy and temporarily increase the peripheral blood stem cells pool with the use of growth factors like CSF. In the early 1980s, method for cryopreservation was developed, and successfully hematopoietic stem cell transplant was documented during 1986 and 1987. And in 1988, 2 successful hematopoietic stem cell mobilization studies was conducted one in Australia, the other one in United States. And after that, during the beginning of the 90s, appears new trials showing the successful of this kind of mobilization for obtaining peripheral blood stem cells. The peripheral blood stem cells is the common source nowadays searched for hematopoietic stem cell transplant. Hematopoietic growth factor used to mobilize hematopoietic stem cells into peripheral blood. The harvest using an apheresis machine via venous access. Monitoring of donor CD34 positive cells can help to determine when to begin the collection. Commonly cited transplantation dose is 2 to 6 million CD34 positive cells per kilogram based on recipient's weight, and the collection is taken to laboratory for processing and may be refrigerated for 24 or 84 hours or frozen for later use. How about the history of umbilical cord blood? In the 70s, investigation of fetal liver hematopoietic stem cells began, but are abandoned. In the 80s, research into alternative stem cell source revived following Chernobyl power plant catastrophe. Dr. Boyce and Broxmeyer found umbilical cord blood contains sufficient hematopoietic stem cells to restore hematopoietic cells and immune cells, and collection posed no potential harm, and hematopoietic stem cell could be cryopreserved and transplanted. In 1988 was done the first successful cord blood transplant by Dr. Eliane Grubman in St. Louis, Paris, in a child 5 years old with Fanconi anemia. In the early 19th, Dr. Sean Kurzberg from Duke University and Dr. Pablo Rubinstein for cord blood from New York has developed many studies that show the umbilical cord blood is going to be a good source for allogenic transplant. Collected from the placenta following full-term singleton birth, the cord blood can be collected before or after the placenta is delivered. Umbilical cord is cleaned and then punctured, allowing collection. The process takes approximately 5 to 7 minutes. The collection bag is rotated to mix anticoagulant to prevent clots. Collection is sent to laboratory for evaluation and processing, especially to know the volume and the nuclear total cells, and the umbilical cord blood collections are frozen for later use. The commonly cited dose for allogenic transplant, unrelated allogenic transplant, is 2.5 per 10 to 7 CD34 positive cells per kilogram recipient weight. Here you can see the total process. You can see the expectant mother. She needs to sign an agreement. The umbilical cord blood collection kit is going to the maternity. The child births. After that, the umbilical cord blood is collection, and the sample is going by delivery to the lab for processing, and then the stem cells concentrate into a 25 milliliters bag is going to the nitrogen liquid. Here you can see the transplant timeline up to 2010, where the autologous is more important than the allogenic. And here on the left, you can see the indication for hematopoietic stem cell in United States up to 2017, where you see in green the autologous transplants, in blue the allogenic transplant. Once again, autologous for myeloma, Hodgkin and Hodgkin lymphoma, and in the case of allogenic transplants, specifically into the malignancies, hematologic malignancies, acute myeloid leukemia, myelodysplastic, and acute lymphoblastic leukemia. On the right, you can see the selected disease trends for allogenic. Once again, the hematologic malignancies for allogenic and myeloma, non-Hodgkin lymphomas are going to autologous transplant. Here you can see up to 2016, in orange, unrelated cord blood, in blue, unrelated donor for bone marrow, in green, unrelated donor for peripheral blood. And once again, the three sources, umbilical cord blood, peripheral blood, and bone marrow, the stem cell isolation, the stem cell transplantation. Before that, the patient needs to go to the conditioning regimens using total body radiation, sometimes ATG, and different chemo like cyclophosphamide, fludarabine, and others. The centralized manufacturing model needs to a donor collection, donor characterization, donor eligibility, the standard reference materials, the bioprocessing at the lab, testing and standards, and the product release testing, harvest and banking. You need to use validation and stability methods and logistic also. Then the cells are thawing and patient delivery to release retesting, and the product is optimal to use like a SURF for hematopoietic stem cell transplant. In this centralized manufacturing model, is very important the quality, because the quality say what you do what you say, prove it and improve it. We know that since the late 80s, we have voluntary standards accreditation, the National Marrow Donor Program, AADV, FACT-SHACI, NETCO-FAT, CAP, and of course, the regulatory and state and local regulations in each country. The HSC processing needs sometimes red cell reduction according to potential events of like ABO incompatibility, sorry. Here you have the red cell reduction because recipient
I believe there's some technical challenge in the webinar. We'll restart very soon.
Do you listen, Aikaj?
Yes, sir. You'll have to share your screen again, sir.
Yeah. Do you listen me?
Yes, sir. We can hear you loud and clear. Just please share your screen again.
Okay. Well, about the processing, sometimes we need to red cell
we cannot
reduction.
see the screen. We cannot see the screen, sir.
Okay. Wait. It's okay right now? Do you see the screen?
Yes, sir. We can see the screen, sir. You can please continue.
Okay, thank you. I'm sorry. Well, once again, into the processing, sometimes we need to red cell reduction. Recipient have anti-donor titer, and we have to look when their anti-donor titer is going up to 1 to 32, and in the red blood cell when you have more than 20 milliliters. In these cases, the potential adverse consequences are immediate hemolysis, delayed red blood cell engraftment, and potential pure red blood cell aplasia. For instance, we need to red blood cell depletion. Here you can see it again. If you have more than 1 to 32, more than 20 milliliters, you need to make the red cell reduction because we have incompatibility sometimes into the ABO. Yeah, you can see the red cell reduction minimizes leasing of red cells and presence of free hemoglobin in the infused product, and normally accomplished through use of centrifugation or sedimenting agent as hydroxyethyl star. Remember, the peripheral blood hematopoietic stem cells do not usually need red cell reduction because in good hands the hematocrit is under 5% generally. The plasma reduction. Plasma contains antibodies, and each blood group contains naturally occurring antibodies to the antigenic labs. For instance, depends on the recipient and donor HBO group, we need to make the plasma reduction. The plasma reduction is done also to prevent volume overload and to minimize storage requirements, especially this, the last one, the storage requirements in the cord blood banks. How about the freezing? Hematopoietic stem cells can be cryopreserved and stored until needed. We use solution is 10% dimethyl sulfoxide DMSO. You need a controlled rate of freezing of 1 to 4 centigrade per minute, and the final storage is in liquid nitrogen at negative 140 centigrade in the vapor nitrogen, or negative 196 centigrades in the liquid nitrogen. Products needing to be stored for more than 1 to 2 days are usually cryopreserved before transplant. At the moment to thaw in the hematopoietic stem cells, when the cells are to be transplanted, thawing is performed. The product is placed into a sterile bag, then is submerged in a 37 centigrade water bath and kneaded gently. We have to remember that the DMSO is toxic at room temperature. And after that, and previously to the infusion, we need to wash him. After thawing, product may be washed to remove lysate cells, free hemoglobin, and DMSO. The solution to use is a 10% dextran human serum albumin mix. We need to mix equilibrates. Product is centrifugated, supernatant express, and pellet is suspended. We need to know the white cell depletion filters must not be used. Caution about this. And remember that the adverse reactions of dimethyl sulfoxide in humans are hypotension, hypertension, anaphylaxis, cardiac and respiratory failure. And these adverse reactions are more common in children. Advantages and disadvantages of each hematopoietic stem cell. We have marrow, peripheral blood, and umbilical cord blood. About marrow, the advantages are engraft quickly, donor may be available for a second transplant. The disadvantages require anesthesia to collect and may take unrelated collection. Peripheral blood advantages are engraft quickly, less invasive collection, donor may be available for a second transplant. The disadvantages for peripheral blood are requires mobilizing agents like G-CSF, also may take up to 3 months for allogenic and related collection because you have to identify the potential donor, and peripheral blood have greatest potential graft versus host risk. About umbilical cord blood, the advantages are readily available, at least 1 month, less invasive collection, hematopoietic stem cells are immunologically naive to allow for greater HLA disparity, and the disadvantages are single unit may have insufficient number of cells for an adult recipient, and donor not available for second transplant. Here you have more advantages and disadvantages of the three sources. I need to put your look in, for example, in cord blood, the disadvantage is a longer time to engraftment according to the count of nuclear T cells and CD34. For instance, the cord blood banks need to have very good samples at the moment of the collection. In the case of peripheral blood, it's very important to know that the risk of graft versus host disease is the main problem because the number of nuclear cells. And in the case of marrow, you need transfusion because the collection is around 10 to 20 milliliters per kilogram of the recipient. For instance, it's better to have an autologous transplant, an autologous transfusion for these patients when is going to be to the marrow collect. Well, the evaluation of transplant is so important. The first step is to determine whether the patient is physically and emotionally capable of enduring transplantation process. We have to know the age, the functional status, the stage of disease, and previous treatment of our patients. The evaluation of transplants include HLA tissue typing, a complete health history, psychological and emotional status for it, bone marrow biopsy, CT, MRI, or PET scan to know potential minimal residual disease, and to know how about cardiovascular, respiratory, renal, and hepatic systems. Don't forget infectious disease testing, and very important, dental evaluation. Here you have the process with the post-transplant risk, prior chemotherapy and or irradiation, some comorbidities, obesity, hypertension, or patients with diabetes with insulin resistance. During the condition regimen before the infusion, the total body radiation, the differences between myeloablative versus non-myeloablative conditionings. During the transplant, we have the 3 SOURCE, the early post-transplant, the patients who need total parental nutrition. You have to look the infections, the use of antimicrobials, and the GVHD prophylaxis. And during the immune recovery, graft versus host disease is very important, and you use steroids, and you have to know kinetics of immune reconstitution. The conditioning regimens prepare the patient by physically making a space, the room into the bone, suppressing the patient's immune system for avoiding the rejection, and destroying all of the potential cancer cells, potential minimal residual disease. Here you can see the process where the conditioning regimen in this case is myeloablative allogeneic hematopoietic stem cells. Before 5 to 10 days before transplant, the patients receive chemotherapy with or without total body irradiation and sometimes anti-thymoglobulin. On day 0, the infusion is done. During the 4 months, the main topics to see are the pancytopenia, the infection, and organ toxicity. During the 2nd month up to the 100 day, infections and graft versus host disease are the main topics, and all the time you have to know the immunosuppression of our patients. In the case of conditioning regimens with reduced intensity conditioning, these kind of condition regimens are indicated to patients with hematologic malignancy due to older age, with comorbidities and extensive treatment history. Once again, the first month, the mild pancytopenia is the main option to look. The immunosuppression is going so far away during the last, during the post-transplant moment. And you remember that the both types of conditioning regimens are associated with nausea, vomiting, hair loss, cytopenia, and immunosuppression. At the moment to do the infusion, we need to know the recipient's name and unique identifier, the product's ID, product name, date and time of collection, date and time of expiration, volume and additives, of course, the ABO and RH type of recipient and product, and red cell compatibility results. The hematopoietic stem cells are infused through peripheral or central venous access. All patients need to receive normal saline or dextrose before the infusion, and of course, they need antihistamine and antipyretics for avoiding the the adverse events. During infusion, leukocyte reduction filters must not be used. A 170 to 2016 micron standard filter may be used. No other medication through the intravenous except saline. Infusions begin slowly, no more than 4 milliliters minute, monitor for adverse reaction, and assess vital signs every 10 minutes at least. And after finishing the infusion, flush product back and tubing with normal saline for use the total nuclear cell and the total stem cells. Every 5 to 10 minutes, you have to monitor for adverse events, and these are fever, pain at the infusion site, lower back pain, hypotension, tachycardia or arrhythmias, hemoglobinuria, hemoglobinemia, shortness of breath, hives, and decreased urine output. During the neutropenic phase, we have pancytopenia. The patients need transfusion support and lack adequate immune function. Many times, hematopoietic growth factor supports it, with special use in the GCSF or granulocyte colony stimulating factors. Sometimes, for improve the red cells, we need to use erythropoietin, and platelet and red cell transfusions are needed. The red cell transfusion trigger is hemoglobin down to 7 grams per deciliter, and the platelet transfusion trigger is 10,000. Sometimes, in unresponsive sepsis with a severe neutropenia down to 200 per milliliter neutrophils, sometimes granulocyte transfusion could be done. And you have to know the broad spectrum by antibiotics, antifungals, and antivirals. The engraftment phase, transplanted of the cell migrate to the recipient bone marrow and begin the differentiation into the various cell lineage, especially hematopoietic stem cells and immune cells. On the right, you can see the engraftment around the 20 days after infusion of neutrophils. And on your left, you have the graft definition, neutrophil more than 500 in 3 consecutive days, platelets up to 20,000 without transfusion, red cells up to 30 per 10 to 3 reticulocytes, and it's very important to know the T cell chimerism, the full chimerism when you have the 95 donor cells, and in the timeline of the process, you have mixed chimerism between 5 to 95%. Monitoring donor chimerism can be assessed to success the engraftment, especially for the withdrawal of the immunosuppressive drugs or administration of donor lymphocyte infusion, like you can see in the diagram in your left. In gray, the recipient, in red, the donor cells, and in this case, the patient needs a donor lymphocyte infusion to get the full chimera. The allogenic hematopoietic stem cells need to know the acute graft versus host disease as a real problem. You remember that the HLA gene complex encodes 3 classes of antigen in the short arm of the 6 chromosome. Class 1 and class 2 are the most important. Class 1 ABC, class 2 DP, DQ, and DR, and DRB1 is the most important. At the moment, to show this kind of options to have the donor or to receive sometimes patients who have developed acute graft versus host disease, I use the solar system to show them the potential city donor or the potential AHLA unrelated donor, because the sun and the main planets are to be the same, but the donor and the recipient could be a minor antigen that non-compare, and these kind of minor antigens could be developed the acute graft versus host disease. The graft-versus-host disease appears into the first 100 days and affects up to 50% of allogenic recipients. The acute graft-versus-host disease have risk factor, and the factors appear to influence development are the degree of donor-recipient HLA mismatch, the female donors who have been pregnant, older donors, and source of hematopoietic stem cell, peripheral blood, more than bone marrow, and post more than recovered blood. Acute graft-versus-host disease show at the first clinical exposition the rash in the palms and soles, skin rash. Also, the patient have nausea and vomiting, stomach cramps, diarrhea. They have also loss of appetite, abdominal pain, and appears also jaundice, and of course, they weight loss. Severity is great, and the targets of the acute graft-versus-host disease are the skin, the liver, and gut. The chronic graft-versus-host disease in allogenic hematopoietic stem cells appear after the 100th day and affect up to 70% of patients. Once again, chronic skin lesions, eyes lesions, dry eyes like Zika syndrome, or lesions, chronic lesions in mouth and tongues. For chronic graft-versus-host disease, we have risk factors. Prior acute graft-versus-host disease, higher degree of HLA mismatch, increased recipient or donor age, donor and recipient gender difference, especially when the donor is a female and the recipient is male, alloimmunization of donor, pregnancies or transfusion, use of peripheral blood stem cells in comparison to bone marrow and cord blood, administration of unirradiated lymphocyte infusion, patient with previous splenectomy, and of course, cytomegalovirus positive status for either donor and recipient. And please, a very important issue is early diagnosis of graft-versus-host disease to prevent irreversible organ damage. Chronic graft-versus-host disease have different lesions, chronic skin lesion, the dry eyes, problems in joints, mouth, and pulmonary or lungs diseases. Transplant recipients need a screening regularly, every 3 months during the first year, every six months during the second one, and annually thereafter. How about infections? After stem cell transplant, patient is at risk for bacterial, fungal, and viral infection. You can see here different phases. The allogenic hematopoietic cell infusion need to prevent before the infusion to know if the patient need to be screened for existing infection, especially bacterial infections involving skin, mouth, or urine tract. After the infusion, up to 50% of patients will develop bacterial infection, gram-positive organism, fungal infection, especially Candida albicans, and viral infection. Therefore, the days 30, bacterial infection are less frequent, except in those patients with central venous line access, herpes virosis, and cytomegalovirus, 15 to 20% mortality rate following cytomegalovirus infection, and severe fatality up to 90% rate of patients with mortality when they have cytomegalovirus pneumonia. After day 100, there are few infections, but remember that patients are immunosuppression, and in this case appears the viral agents up to 40%, bacterial account for 30%, and fungal agent account for 20%. Here you can see different phases, pre-engraftment, post-engraftment, and late phase. The days that are to 0 or infusion to 30 days. And in this case, you have neutropenia, barrier breakdown, T cell and B cells are going down, and the gram-negative bacilli and gram-positive organisms and fungi are the main microorganisms. The viruses are going during the whole process, especially with herpes simplex virus. The cytomegalovirus appears into the second or post-engraftment phase. But you have seen that other viruses like respiratory and enteric or HSC or varicella zoster virus or Erdenebayar could be appeared. More than 1 year after transplant, long-term survivors of hematopoietic stem cells are at risk of developing complications. 2 to 3 hematopoietic stem cell transplant survivors develop at least one chronic health condition. They are immune alteration like infection, cardiovascular like cardiomyopathy, congestive heart failure, pulmonary fibrosis, interstitial pneumonitis, hypothyroidism, thyroid cancer, and chronic kidney diseases. And the liver, graft-versus-host disease, chronic graft-versus-host disease, hepatitis B or C, and remember the potential iron overload. And of course, second cancer, solid tumors, hematologic malignancies, and the post-syndrome lymphoid disorder, post-transplant lymphoid disorder. The hematopoietic cell registries are needed at the moment to not find a sibling donor. These registries are the connection between patients searching for a cure and life-saving bone marrow donors. There are largest and most diverse donor registries in the world and help more patients get the transplant they need. You have to know and remember approximately 70% of patients who need a hematopoietic stem cell transplant relate to registries. And we have many registries around the world, the National Marrow Donor Program, Be the Match in the United States, the Bone Marrow Donor Worldwide. In Europe, we have the Anthony Nolan Be Match Save a Life in United Kingdom, and for cord blood, public cord blood banks, the NetCore FAC organization. You can see on the right that only 2% of people in the United States are registered as stem cell donors, and you have to know the younger donors are associated with better survival. For instance, it's very important to introduce the needs of potential donors in our countries because you have a gift to cure blood cancers and other malignancies. On summary, there are 3 types of hematopoietic stem cell transplants: autologous, SYNGENEIC, and ALLOGENEIC. They are used to treat non-neoplastic immune disorders to malignancies. Allogeneic transplant selection is based on HLA match. There are 3 main sources of hematopoietic stem cells: bone marrow, peripheral blood, and cord blood, with advantages and disadvantages. These hematopoietic stem cells have different processes, and some of them need cryopreservation. We have seen the whole process of hematopoietic stem cell transplant, where you know to have 2 different conditions and treatments, myeloablative and non-myeloablative, for those patients who are older or who have many comorbidities or have an excessive history of treatment before the transplant, and how is going to the immunosuppression and the different infections, fungal, bacterial, and virus in different phases of the post-infusion term. And 7, the international donor register available for identify potential unrelated donors. Let me express my wish to thank my mentors, Winston Ho, Pablo Rubinstein, Elian Gluckman, Juan Garcia, Sergio Querol, and Carlos Solano, who helped me into my trainee in stem cell transplantation. that began many years ago in the UCI with Winston Hall in 1995. And at the moment to show you this talk, I have many memories because I am working in stem cell